So thank you very much. Well, our next set of presenters get together. Let me briefly introduce our moderator, Dr. Robert Glenn. Dr. Glenn is a professor of biostatistics at Brigham and Women's Hospital and Harvard Medical School. He's part of our planning committee that put together this symposium, so we thank him for his contributions. He's a methodologist who's been focused on a variety of topics, including missing data and in some clinical areas that are very interesting and related to vision care. So Dr. Glenn will moderate this, and we'll have three speakers today.
Our first speaker, we have 3 talks in this session. I think they very nicely illustrate a variety of methodologic challenges in settings of in-stage kidney disease and cardiovascular disease, and a variety of approaches, cluster randomized trials, and policy interventions and their impacts, and time-varying confounding that arise in these settings that are very challenging to evaluate. Our first speaker, and I'd ask the speakers to try to stay to within 15 minutes. We have 5 minutes for questions, please. Our first speaker is Vince Moore. He's a professor of medical science and the Florence Pierce Grant University Professor of Community Health in the Department of Health Services Policy and Practice at Brown. He's made contributions over many years to healthcare delivery, evaluation, measurement of delivery processes and outcomes in frail and chronically ill older people. Vince.
So I'm hoping there's no tricks to this. I'll just move along. So my co-authors. So Sebastian asked me to do this talk sometime this past year, and I had this great idea, but I had to get some smart people to actually work with me because I'm just the voice piece here. So the idea was there was this wonderful experiment in a policy innovation or policy change, which I'll be describing. And I thought, well, wouldn't it be interesting to take an econometric perspective and a sort of propensity matching perspective and see what came up? And we learned probably a lot more than I would have ever guessed in the process. So first, acknowledgments. The funding is from NIDDK to Shailander Swaminathan, one of my co-authors, and he and I work on a contract from Kidney Care Partners. It's an industry collaborative to monitor reductions in one-year mortality amongst dialysis patients, which is sort of how I got into this thing in the first place. But they've had no connection whatsoever to this work. So what I'd like to do is to examine the effect of erythropoietin stimulating agents, ESAs, on survival and end-stage renal disease using basically 2 different approaches. One is sort of a difference in difference design that exploits a Medicare payment policy shock, and the other is a propensity score method with multiple imputation of the outcome variable, which is from Roe Gutman, one of our other co-authors. And I'll discuss briefly some of the implications for comparative effectiveness research and then future directives. So, for those of you who don't know, clinical trials of ESAs found increased thrombolytic risk in cancer patients with mild anemia. The clinical trials have generally found no survival benefits amongst people with sort of with regular anemia, but there have been adverse outcomes reported when people are treated to a quote-unquote high hematocrit or hemoglobin level versus a relatively lower hematocrit level amongst ESRD patients, and there was, but a high percentage of those people are treated. So with that in mind, the FDA put out a black box warning in 2007, and then in January 2011, Medicare actually instituted replaced a total fee-for-service reimbursement of ESA and put it within a fixed sum bundling whenever you have a dialysis treatment. So we examined the impact of bundled payments on ESA. So we looked at about almost 400,000 incident patients with end-stage renal disease receiving dialysis treatment between January 2009 and September 2011. We used the REMUS system, which is a relatively real-time system. It's much more up-to-date than the USRDS, for those of you who are familiar with it. It has information on selected ESA use, hematocrit levels, mortality. We looked at all incident ESRD cases and baseline clinical characteristics, their comorbidities, hematocrit, albumin, other, obviously age and race as well. all monthly ESA use and hematocrit levels were examined. We actually did the comparison with the outpatient claims and was just unbelievably surprised and delighted at how great the correspondence between these two sources of information, meaning that we don't necessarily have to wait for the USRDS data. All cases are tracked through death or censoring. For those of you who don't know, Social Security just sort of had a big bundle of new deaths that they sent out to the world, and then they retracted some of those deaths, so it's made life very difficult for those of us following things. So this, the red line here is hematocrit of people at 36, over 36, and the x-axis here is basically time for these incident cohorts in quarterly periods. And so we see that there's a dramatic reduction in the proportion of people at high hematocrit level at the time of baseline who got ESAs immediately following the last quarter of 2010, which coincided with the bundling experiment. So we sort of looked at this and said, so here's the difference in terms of time, where you're looking at the x-axis is is hematocrit level, and the different colors. The red is the third quarter incident group in 2011, and the black line is the first quarter incident pool. So from a policy perspective, CMS got it just right. The wrong people who are getting hematocrit at at too high a level are being dropped, and whereas people at under that are more or less staying about the same. So that's the policy effect. That's the stage one of the policy. And so basically we see that it's mostly for patients hematocrit over 36. And so the question is this a good sort of instrument for as an exogenous policy shock? The trick here, however, is if it's responsive to, if hematocrit is the thing to which people are gearing it, but hematocrit changes when you give an ESA, it's not a great stratification criteria. So while we do observe a heterogeneous policy response in terms of the treatment, we don't have a tool necessarily to see that heterogeneous outcome or because of the stratification. So that took us a while to figure that one out, and but that gave us some choices into how to do this. And so one option we had was sort of do a pre-post comparison, which would assume a validity of the D&D model. We thought about doing a regression discontinuity, but because the policy response seemed to be so precise at 36, it's not a random fluctuation around that point. We thought about then stratifying by providers ESA sort of propensity to give a lot of ESA, the way Sebastian and his colleagues did in an earlier paper, but that had some other issues associated with it in terms of very big inter-provider differences in outcomes already that we observed from other sources. So we then decided to go with an incident cohort on the basis of the new policies. We looked at new admissions in 2010 versus 2011. They look very similar, but nonetheless we decided to make the adjustments. We used 180-day mortality to ensure sufficient time for the mortality data to be complete, because these data are just about 1 quarter out, so we have data from April. This is April 2012. We compared the mortality differences by strata with baseline hematocrit, and the small sample sizes made it imperative for us to sort of group into larger groups of hematocrit level rather than the more refined levels that we could do for the first stage. The groups are quite similar in terms of baseline hematocrit, baseline age, catheter access, etc., from year to year. And then here are the adjusted results. And this is a little disconcerting because it's about a 1 percentage point increase in mortality for the post-bundling. And that's what we found here. We found the same for the 90-day, which has a steeper hazard. The results are much smaller for the over 36, and so we thought that might where we'd expect it. We initially thought that we'd expect to see a mortality benefit because people at over 36 were not going to be getting it, and we did not see that. We saw no difference whatsoever. The effects of the bundling change on the short-term mortality was sort of a small differences in that 180-day mortality in that under 36 hematocrit group. There was a general uptick overall mortality in 2011. We're beginning to explore what might be behind that. There could be data issues on the 2011 mortality data, but there also could be things happening to people before they begin their ESRD treatment, before they begin dialysis with their clinical nephrologists. So we said, let's take another look at this, put aside the bundling issue, and we went and looked at this from the point of view of propensity scores. So we wanted to look at the impact of the policy at outcomes in the entire population. So we asked the question, can we compare the outcomes of ESA among treated and untreated ESRD patients based on sort of ever versus average ESA treatment using propensity matching or never had it, a group. And so we used a multiple imputation of the outcome using propensity scores. And this is from Roe Gutman, who's one of Don Rubin's students. And this is basically, you'd select only observations that overlap between the two groups in terms of the covariates. We create a subclass, these sort of knots on the propensity score, in places where there's at least one observation, because we're essentially streaming these people out on a covariate pool. And we're essentially trying to use the one group to estimate the outcome for the other group, sort of using a multiple imputation approach. Effectively, it ends up being quite similar to the technical approach that you would use for propensity scores, but it starts with a theoretically different model. We also, because of the imputation, we take lots of different trials of the pool, using a Bayesian approach for the posterior distribution of the betas of the exposed and unexposed populations. We calculate the mean and the standard deviations for the average treatment effects on each of those sort of completed data sets. We ended up with about 35 different data sets for pools. We assume, of course, there's the missing data is missing at random. BMI had the most missing data. Hematocrit was relatively little missing data. Most of the other covariates had very little missing data. We also assume that there's no unmeasured covariate, the standard assumption that is uncorrelated with the covariates used and their interactions. The treatment group includes all people who received EPO in at least one visit. So it's a very extreme distribution, sort of just saying you got it only once or twice otherwise, over a maximum of 3 years versus those who never used the EPO. Over 92% of the people that receive EPO, get it at all, get it in the first dialysis treatment or within the 3 months of treatment. So it's a fairly quick yes or no, and there's a lot of variation by provider. So this is more a prevalence than the incidence sample I described before. The top rows show you the number of individuals, and you see most people are in the EPO receipt group, and there aren't very many in the non-receipt group. But otherwise, their sample distributions in terms of their characteristics are not hugely different. There's a larger group that have CHF with at least one dose of EPO. We broke the propensity scores up into deciles, and the reds are going to be the smaller group, but it's basically the overall distribution within each one of these deciles of the sort of the average propensity score distribution underneath that. And they generally fit reasonably well. The first and last deciles somewhat less well. But once we balance the subclasses are essentially deciles, and we show that basically they're relatively well balanced, and the average increase of the variables is relatively the same, whether it's the dichotomous or the continuous variables like hematocrit or age. So when those are compared then across the samples, we here see about a 2 to 3% benefit associated with EPO in the sort of the sweet spot where the lower the lower hemoglobin level would be, those people who might be candidates. By the time you get up to about hematocrit of 36 or 37, which is where the black box warning work, the standard deviations become much broader. And once they're up much higher, it's it's on the 0 point. We did another example to try to replicate the trial very briefly, and we again used the observational data to try to say who is being treated to the top and who is being treated sort of at the bottom level. And so for every hematocrit level, there's tied to an EPO administration during the same month. So we could actually look at pairs and see on average whether an individual patient was being given EPO or ESAs at the time when their hematocrit was lower versus higher. And then so we basically looked at the 32 to 34 group, which was amongst the recipients of the hematocrit of ESAs versus those treated to a much higher level, just even higher than the 36. Again, here we see some significant differences across the groups, but not hugely different. But we do see a very large mortality difference in the bottom row here. And again, the same approach for the propensity matching was done. We could see that here at the bottom right, the top decile. Yes, is that going to work? No. Anyway, the top decile in the bottom right-hand corner for you all is. Thank you so much. There we go. That's going to be that's higher on average than the others are. But as we showed the same kind of balancing table before, I didn't have time to present all that, but there was actually reasonably good balance for all the groups. And here we actually replicate the trial in terms of seeing a fairly reasonably a large effect of getting ESA at a high, when you're being treated to a high level, is associated with about a 17% increase in mortality, which is an odds ratio of about 2.7 increase in likelihood of survival under that decreased likelihood of survival under that circumstance. So using a crude classification of any versus ever the ESA use, we observed small reductions, about a 1% on average, with ESA use for 1%, 2%, for both 180 as well as 365 days. I presented the 80, but we also did the 365. However, the small number of never exposed individuals and differences in their clinical background features sort of gives me pause, gives my statistician friend less pause. The competing risk of survival and exposure, given the high rate of early mortality, also raises questions. A very high rate of early mortality, and how maybe we could drop off the first 90 days of the mortality distribution because it works there. And the trials of the impact of ESA on mortality have been mixed to negative in the lower hemoglobin levels. So that sort of gave us some pause. On the other hand, the results of the propensity score analysis to treating to high versus treating to low, it does replicate the RCTs of treating to a high level. But since 90% and since 90% of ESRD patients do ultimately receive ESAs, it's important to know that treating to too high a threshold is dangerous and increases the 1-year mortality substantially. And so the issue is how much can we quantify that and characterize in the real world who is being treated that way. But nonetheless, there's this sort of post hoc classification of treating to a clinical target, which is a very big challenge in doing any kind of database retrospective work, because you're sort of tied in trying to replicate a clinical decision. And there's the competing risk of mortality and the opportunity to shift from a high treatment to a low treatment target, and might that get in the way? As somebody begins to approach death, somebody might be giving them more ESA to make them feel better, or to have some other idea in terms of that outcome. So what we thought was interesting here is the notion of you being able to use the policy shock as an instrumental variable and to see whether that is possible. But if that policy shock also has an effect on the stratification variables, it means that you're not able to actually identify as easily that group where you think there might be an adverse effect because there's a heterogeneous response. So that means the group has to be large enough to be able to detect it in the overall, and the effect size has to be large enough to be detected in the overall population. Using propensity scores with observational data to test the effect of sort of these clinical treatment protocols, I think that still requires more work. We have to actually explore this more fully. I think the data we have gives us some handle on being able to do that. The different approaches are sort of broadly consistent, but then they're not consistent with the clinical trials, which sort of makes us a little bit worried about the interpretation. But again, clinical trials have not actually been done with exactly this patient population. So what we're going to be doing is trying to further explore the use of propensity-adjusted outcomes within this D&D framework using the propensity scores as the other approach within the incident population, where we are a little more confident as to who's getting it and who's not, and doesn't have that long survival history. We'll specifically test whether the propensity-matched ESA effect on mortality varies as a function of changes as to who's getting it, because we can actually have that who's getting difference, because we've seen that quite clearly. With the propensity match, we might be able to detect something in the over 36 group. We want to be able to incorporate the natural clinic, between clinic provider variation in terms of how they've responded. It's not just what their past history was, but to see whether clinics sort of said, okay, we're going to stop doing this and see what happens at that juncture, so that there's somewhat less confounding by indication without as much of a quality problem from provider to provider. So we'd like to be able to take advantage of the contributions of sort of traditional pharmacoepi approach, but use within the context of some kind of econometric thinking about how taking advantage of these policy analysis works. But since the policy changes are often crude, we're going to have to be more creative in actually thinking about how to make that work properly. And I think that we may be able to manage that with other forms of stratification using a risk stratification approach. Thanks very much.
I think in the interest of time, we'll hold questions till afterwards. Thank you. Our second speaker is Dr. Nitish Chowdhury. He's a practicing internist at the Brigham and Women's Hospital, as well as a PhD in healthcare policy. He's led numerous studies on cost effectiveness, on adherence, and ways to evaluate adherence, both observational and randomized. And the title of his talk is Implementing Randomized Effectiveness Trials in Large Insurance Systems.
Thanks, Bob, and thank you, Liz. Just by way of disclaimer, I'm a little different than perhaps most of the people in this room insofar as I'm more of a design interested individual than a methodologically analytic interested individual. And so what I'm not going to present any equations to you today. I'm going to talk to you about design. And I'll sort of glance at a few things that I often refer to Bob for guidance on when we talk about clustering and what that has to do with sample size. But I really want to focus on design. And a lot of my work, as Bob mentioned, is in partnership with large insurance companies and large self-insured employers in thinking about how to design and evaluate quality improvement interventions in that context. And so when Sebastian asked me to speak, it's sort of about this topic. In the context of comparative effectiveness research, this is really health insurance and delivery services are really a central priority, as we all know, in the framework of CER. And by definition, many of these interventions or many of the studies are done in partnership with large insurance companies, and this has many clear advantages. It promotes generalizability. It's done in the setting that will ultimately use the data which we find, and it also speeds time to uptake or implementation of positive results. So, for example, the trial I'm about to show you will be actually implemented in practice within a year of actual results being published, which is perhaps a faster turnaround than is normally seen with most health services research. But, of course, doing a trial in this context, or doing studies in general in this context, and I'm going to focus on the randomized trial, really creates unique pragmatic and methodological challenges. And that's really what I want to spend the next 10 to 15 minutes or so talking about. And these really need to be carefully considered in the design and analysis of these studies. So I'm going to hit a little bit on claims lag, sample size, clustering, communication with beneficiaries, and co-interventions in large, broad terms. And I'm going to use an example that we did, as I mentioned, and the lessons of which have really guided new interventions that we're now launching using these same sorts of methodologies. So here's the background. Our trial was called MI-FREE, which was the post-myocardial infarction free RX event and economic evaluation. And it was really motivated by an observation that many of us had for decades now, which is that adherence to evidence-based medications remains appallingly poor. So in the context of myocardial infarction, which is a disease which we focus a lot on because interventions should have relatively rapid results in terms of changing quality and economic outcomes. So within 2 years of initiating therapy, only half of patients remain adherent to their prescribed statins, beta blockers, ACE inhibitors, angiotensin receptor blockers, which are, of course, the bundle of medications that are evidence-based, grade 1A, in most cases 2A for ACE inhibitors, post-MI medications. And not taking these medications, which have demonstrated efficacy from large-scale clinical trials, perhaps the largest clinical trials of any type for any disease, have profound clinical and economic consequences. So there are lots of reasons why people don't adhere to their medications. It's a complex interaction of patients and providers and healthcare systems. But of these reasons, drug costs or knowledge of drug costs, including providers' knowledge of drug costs, appear to be central. And so this was really the motivation that if we look at the observations that have been made in public and private health insurance, that utilization varies according to the comprehensiveness of coverage, as in people who have better coverage use more evidence-based medication, then eliminating out-of-pocket costs for evidence-based medical therapies may, in fact, promote adherence and improve outcomes. A pretty logical, straightforward, easy idea. Well, let's make it free. And this, in general terms, in the policy community is called value-based insurance design or evidence-based plan design. And this idea has been adopted by payers already. So across the country, hundreds and hundreds of large self-insured employers have plans like this in which they eliminate cost-sharing for evidence-based medications of some sort or the other. So diabetes, hypertension, asthma, COPD, depression in some cases. And observational studies led by our group and others really support the ability of this strategy to increase adherence, but its impact on clinical outcomes and spending, the so what kind of question, really remained unanswered until we began our study, or rather until we released the results of ours. So our study, which was begun in 2007, really set out to evaluate a comparative effectiveness question. I didn't realize I was a comparative effectiveness researcher until I sort of got part of the way into this study, and that we were comparing two insurance systems, right? One is full coverage, and as you'll see, the intervention is very simple, versus usual prescription drug coverage for post-MI secondary prevention medications. It was a small suite of medications. So here's our basic design. We identified, we used health services techniques to answer a clinical question and a policy question. So we identified people prospectively who were beneficiaries of Aetna. As you all know, Aetna is one of the largest health insurers in the country, and we used health services claims, as in discharge claims submitted by hospitals to Aetna for processing, and used validated algorithms which have a high specificity to identify people who we were pretty confident had an acute myocardial infarction. We excluded some people, for example, those over age of 65, because I learned it was illegal to randomize those people, and so rather than go to jail, we stopped randomizing. And then we cluster randomized, and this will become relevant in a second. So this process of what I'm laying out for you, I'll get back to in a few minutes when we talk about some of the methods. So we randomized at the level of the plan sponsor. So all of us have some insurance, presumably, and our plan sponsor is the entity that's responsible for that insurance. So our employer or our union or other sort of general agency of some sort. And we randomized at that level, and I'll explain that choice in a few minutes as well. And again, the intervention was very simple. Either they got these drugs for free or they got their usual level of insurance coverage. We contacted patients twice, once by phone and once by mail. And that's it. And so the next time, people in the control group were told, we're sorry you had a heart attack. There's some medications your doctor may have prescribed you. You should really take them. And in the intervention group, we said, we're sorry you had a heart attack. There's some medications your doctor may have prescribed you. We think they're so important that we're eliminating copayments for these and coinsurance and deductibles. And the next time you go to the pharmacy, you won't pay anything. So we changed the authorization codes in the insurance structure to allow for this to happen. And that was really it. Then we saw what happened. And so our structure, as I said, was this cluster and block randomized design. And so we randomized your plan sponsors rather than individual patients, and we did this predominantly to avoid what we call the water cooler problem. Whereas if you and I are both employees of a given plan sponsor and we both happen to have an MI and we both happen to show up at the water cooler at the same time, and you said, hey, I'm getting my drugs for free, and I said, hey, I'm not, one of us is going to be pissed, and it's probably going to be me. And so from the perspective of plan sponsors in the real world, real employers making decisions about coverage for their beneficiaries, this idea of the water cooler and happy employees is not a subtle point. And so this avoided the realities, this allowed for the realities of patient care by cluster randomizing. Of course, this choice led to other problems, specifically that plan sponsors may really differ from each other. So if we ended up with a large plan sponsor in one group, which as it turns out we did, and a small one in another, they may differ from each other in terms of the number of employees with an MI and the nature of the coverage that they provide and or the nature of other things that they might do. And so we block randomized. And so we before beginning the trial, identified those features which we thought might influence our outcomes of interest most, in as pragmatic a way of doing this as possible, assigned plan sponsors which were done prospectively into one of these blocks and then randomized within those blocks. So we had 6 blocks, 3 based upon generosity of usual insurance coverage, and 2 based upon whether they're large or small. And so we had 6 and we randomized within them. So our primary outcome measures were clinical. So we sought, again, to answer the so what question. And so we took a composite clinical outcome that you would typically see in a new drug trial, the ones that Bob helps run, which was a composite of first major vascular event, so having another heart attack, stroke, heart failure admission, or revascularization, as in having a CABG or an angioplasty stent insertion. And because the last of those, as any of you who read the newspaper know, is the most squishy of them all and potentially done for discretionary reasons, we had pre-specified secondary outcomes which excluded those, or looked not only at the first event, which is the typical approach, of course, with most trial evaluation, time to event using Cox models with a single failure time. We used multiple failure time models to look at total events, which is, from a policy perspective, you may, of course, care that you've prevented the first new MI or the first new stroke, but you also may care that they had multiple new strokes and multiple new MIs, and those certainly have economic consequences, and so we measured those as well. We, of course, looked at medication adherence, which is the causal mechanism. So imagine this was a comparative effectiveness study of 2 cholesterol-lowering drugs. We want to know that they both lowered LDL and therefore both changed mortality, and so we looked at that and as well as spending. And we used health services claims and algorithms that you all are familiar with to assess our outcomes. So we used real policy methods and health services methods to both design, implement, and evaluate the trial outcomes. We used, as I mentioned, time-to-event modeling and generalized estimating equations for our adherence and economic outcomes. So here was really what happened with the trial, so we initially identified over the course of about a 3-year period, prospectively, about 3,900 plan sponsors. About 900 of them said that they didn't want to participate, and they did this for a wide variety of reasons. So many of them are small plan sponsors that say we don't participate in research, even if it meant nothing for them economically. The insurance company was picking up the tab for fully insured individuals. Others, perhaps the most interesting reason from my perspective was that some large plan sponsors have unionized members, and unionized members get insurance through multiple different insurance companies. You can pick your plan, and they say, look, if we give free drugs to our Aetna beneficiaries, then what happens to the United and the WellPoint and the Blues and all the rest of them? And so they said, we cannot play, even if we like this idea. And so, as it turns out, as far as attrition because of plan sponsor opt-outs go, it wasn't that bad. We still ended up with about 3,900 plan sponsors, which were roughly equal to between the two groups. A few more people ended up in the usual coverage group because we had one large plan sponsor who ended up by chance alone in usual coverage, but the number of plan sponsors, which was the level of randomization, was equal. We lost a few people, and I'll get back to this in just a moment, between the time they were discharged from a hospital and we identified them for randomization. And this concept of insurance churn features prominently when thinking about interventions like this. And we followed people up for just over a year. So baseline characteristics between the two groups, like to see in most randomized studies, looked pretty good, between nicely balanced. And with apologies, I'm just going to quickly slip through this. This is the basic result of the study, which looks at medication adherence. So the top group of bars look at adherence measured as a proportion of days covered. So for a given patient in a given time interval, how many days of medication do you have available to you? The bottom group of bars takes that same number and makes it binary, as in, are you fully adherent or not, defined usually as in conventional method using an 80% threshold. The red columns are full coverage. They're the intervention group, and the blue columns are the control group. And we see across these disease classes, ACEs, ARBs, betas, statins, that we see about a 4 to 5 to 6% improvement in adherence, so about 5% on average. So a modest change in adherence, and one in which you'd say, if I stopped here, you'd say, I'm not sure what to make of this. So what we did, of course, seek to do was look at clinical outcomes. And so on the left, on your left, is the primary pre-specified outcome, which is this major revascularization major vascular event or revascularization. We see lower events with full coverage, but a hazard ratio of 0.93 that is not statistically significant. When we take out revascularization, we, on the other hand, now see something that is statistically significant, as in a 14% reduction in rates of major vascular events from a very simple intervention that involved only copayment changes. If we look at the economics of this result, here's really what we see. And so this is now a red, again, is full coverage. Blue is usual coverage. This is cardiovascular spending broken down into buckets of pharmacy spending, medical spending, and total spending. The top groups of columns deal with patients, and the bottom group of columns deal with all spending, patients and insurers combined. And we see, of course, if we start at the upper left-hand corner, that pharmacy spending went down for patients. We gave away drugs for free. Of course, pharmacy spending should go down. It was nice to see that. Medical spending also went down. So because patients don't go to the doctor more or aren't getting hospitalized and not paying co-payments for their ambulance rides, they also have a reduction in medical spending. And so overall patient spending went down. In this case, it's about $350 a person over a year's time. And if we look at all spending, it's about $500 per person in reduction in out-of-pocket costs for patients. When we look at total spending, we see slight increases in insurer-based spending. That's why total spending goes up for drugs. Slight reductions in medical spending because of, again, reductions in these major vascular events and other things that are way more expensive than the drugs we're evaluating. And overall, an almost significant reduction in cardiovascular spending. But, as a conservative assumption, which is what we made, says there was no increase in spending. So we're providing more generous coverage without increasing spending and improving quality, which we consider to be an economically dominant result. So for the next couple minutes, and sort of focusing again on the methods from a design perspective, I just wanted to talk about the lessons that we learned from this process and the things that may be useful to consider as we think about interventions like this in the future. And so as I mentioned, we identified people using claims data that were rolling into the insurer and then being identified by us and then going out and randomizing them. And that whole process adds in a couple of levels of a delay. So first of all, submissions from hospitals take a while to roll into the insurers. Then you have to actually prospectively look at them. And so we looked at these claims every 2 weeks, which convincing an insurance company to devote somebody to run algorithms every 2 weeks and then send them to us was a bit of a chore at the beginning, but nevertheless for us every 2 weeks. But imagine if you did this every 2 months or every 4 months or 6 months. The design delay there has significant implications. And then once you even have identified the individuals that are of interest, there still is a process here that we have to somehow make sure they're eligible and randomize them and reach out to them and change the authorization codes. And so there's an intervention here. So we ended up doing this in an average of about just under 2 months, so 49 days. Which was better than we had expected. But nevertheless, you could imagine when we think about interventions like this prospective process of identifying, especially for interventions that are time-sensitive. You want to get to people before they stop taking their medications just after they've had their heart attack, so it's very time-sensitive. But these design features certainly induce a lag that threatens even the best prospective policy studies like this. Secondarily, there are lots of threats to sample size as we think about this process. So even though we dealt with one of the largest insurance companies in the country, covered lives of between 14 and 16 million patients, there's still things which can undermine the sample of even a very common disease. So plan sponsors opt out, and as I mentioned, some are unwilling to experiment. We use what we called an opt-out approach in terms of recruitment. So we said that the insurance company was willing to tell their plan sponsors, if you don't want to play, let us know, as opposed to we have to sign you up. And that approach led to us including most of the people who we could. But imagine if you didn't have that high level of support. Insurance churn is a very common phenomenon. All of you are familiar with it. People change insurance companies when they change jobs. Employers change insurance companies when they renegotiate benefits. And this can threaten both the eligible pool. We lost 5% of people in that 2 months between when they had their heart attack and when we actually got to them. And also follow-up time. It certainly truncates things there as well. Patients may not be willing to participate in interventions that are run by insurance companies. Of the rank of sort of people in the healthcare system, I would imagine that insurance companies rank near the bottom in terms of trust from patients, and for sometimes legitimate and sometimes illegitimate reasons. And this occurred even in the case of providing free drugs to patients. People said, I don't trust this intervention. It was very, very few, but nevertheless, that can happen. And so communication strategies here are critically important, and we had carefully scripted approach. Design effects, there's purposely fewer words here than on any of the other boxes. Clustering introduces a design effect. A design effect influences sample size. You need a larger sample size, and so we assumed for that when we were doing our projections. But nevertheless, this could be of certain relevance. Co-intervention is a chronic problem in the real world. And so from the perspective of internal validity, these are difficult things to deal with. Insurance systems undergo changes on a very frequent basis, and these could really confound the exposure-outcome relationship that is of interest to us. Things like benefit design changes and open enrollment, which happens every year, loss of patent protection for drugs, formulary shifts, disease management programs, other quality improvement interventions. And so we dealt with this by randomization and by knowing about pre-assignment stratification of things that we knew were going to happen. But sometimes these are a little bit more challenging to deal with. So in conclusion, this strategy that we evaluated, providing full drug coverage for post-MI medications, increased adherence. It reduced rates of major vascular events, but not revascularization. It lowers patient out-of-pocket costs and didn't increase spending. And so the intervention itself was a success, and Aetna will actually begin waiving copays for post-MI medications beginning in January of 2013. It leaves open the big question of why adherence still was horrible. And the next suite of studies will take the lessons that we learned here to actually implement them. And so this trial, MI-Free, really demonstrates the ability to conduct clinically and policy-relevant studies in a real-world setting, and also the challenges in doing so. Thank you.
Again, in the interest of time, I think we'll forego questions till afterwards. Our third speaker is Alan Brookhart. Alan is a statistician by training who is an associate professor of epidemiology at the University of North Carolina in Chapel Hill. He's written extensively on methodological issues related to confounding healthy user effects, propensity scores, instrumental variables, and also has a deep substantive interest in the specific area of treatments for kidney disease. And Alan's talk is entitled Comparative Effectiveness of Intravenous Iron Formulations in End-Stage Renal Disease. Alan.
Good afternoon, everyone. Thanks, Bob. So I'm going to present some preliminary results from an AHRQ-funded study on the comparative effectiveness of IV iron formulations. So I apologize in advance. I'm not going to be presenting any new methods, but this is methodologically challenging work, and I'll discuss some of these challenges and highlight some interesting methods issues along the way. So I'd just like to acknowledge the DECIDE program, AHRQ's DECIDE program that's funded this project, and Barbara Bartman, the project officer, as well as my collaborators from UNC Chapel Hill and Stanford. I also want to acknowledge that I've received research support from Amgen and have been an unpaid scientific advisor for Amgen and Pfizer. So I'd also like to acknowledge Vince, who's already introduced the topic, and so I'll spare you from going through all of the background on anemia and end-stage renal disease. But just wanted to add one other thing to what Vince has already discussed, and that is that anemia is also managed with intravenous iron in addition to recombinant erythropoietin. I think this has sort of been an ignored co-treatment in this population. So I'm going to skip the background and go right to this plot. And this is very similar to what you've already seen, although I don't have its current data. But this is showing you trends of EPO dosing, iron dosing, and hemoglobin in the dialysis population from 2002 to the end of 2008. And what you see is ESA or EPO dosing rising until about the end of 2007, and this is when the FDA issued a black box advisory for all the erythropoietin stimulating agents, and then it drops off. Iron use, however, has risen across the decade, and I believe continues to rise according to current data. Meanwhile, hemoglobin rose through 2007 and then fell off, and Vince's data suggests that it's fallen off a whole lot more since the end of this chart. So this raises a couple of interesting issues. The first thing is, where's all this iron going? So it's not being used in hemoglobin to make hemoglobin. Hemoglobin's dropping off. The human body has no way of getting rid of excess iron. So presumably, dialysis patients now have a lot higher levels of stored iron. So this is sort of interesting, and this raises the question of whether this is good, whether this is a good thing. And the truth is, we really don't know. There's very little data on the comparative safety or effectiveness of different IV iron dosing strategies. There are a few trials. They're very small. They're typically very short duration. There are a couple of observational studies. But really, there's a lot that's unknown about this topic. However, there is reason to be concerned. There's a theoretical basis to believe that overuse of iron may increase cardiovascular risk. Iron is very reactive and can lead to lipid radicals that can damage the vasculature. Bacteria need iron to grow, so overuse of iron may increase risk of infection. There's also a connection between the IV iron formulations and hypersensitivity reactions. And so these issues are the motivation for our AHRQ study. So this study really addresses two gaps in the literature. One is the comparative safety and effectiveness of the two different IV iron formulations that are in widespread use in the U.S. market, ferrogluconate and iron sucrose. These are very different pharmacologically. Iron sucrose has a long half-life. It doesn't bind the iron atom very tightly, so there's a lot of transfer of the iron atom from the iron sucrose compound to transferrin, the iron transport protein, whereas ferrogluconate gets taken up very rapidly, and the iron is stored immediately. So iron sucrose, it's reasonable to believe may actually be more effective. It may lead to more available iron, but it also may increase risk perhaps of infection because of greater iron availability. So the other issue is how should you provide iron? So there are really two different dosing practices that are commonly used. One is a maintenance dosing approach where you provide very small maintenance doses every week or two to dialysis patients with the aim of basically maintaining iron reserves. And the other approach is essentially sort of a watchful waiting where you don't give iron unless iron indices fall below a critical threshold, in which case you would initiate a sequence, sort of what's called a bolus sequence. You would provide a lot of iron over consecutive dialysis sessions aimed at replenishing iron reserves. So I'm going to talk today about one of the studies that we've done looking at this issue of the safety and effectiveness of bolus versus maintenance dosing. So the data for the study come from two sources. We have data from a very large dialysis provider in the U.S. with about 1,500 units that has about, at any point in time, about 150,000 patients. So we have really rich clinical and laboratory data from this system. We get labs every month to 2 weeks. We have all the individual treatments that are administered in the clinic. So every time iron is given, we see a record of that. We have rich clinical data. We have an indicator of what kind of vascular access is being used. So we've merged this clinical database with data from CMS, data from Medicare. So the Medicare data basically allows us to see what's happening outside of the clinic. So if a patient has a heart attack and is admitted to the hospital, this information may not flow back to the clinic, but we would see it in the CMS claims. We also get date of death from the CMS data as well as cause of death, which is reported through the ESRD death notification form. So in our study, we're using a variety of different epidemiologic methods. We're using essentially a case crossover design to look at acute effects that occur days to a week or two after exposure to iron. We're using a traditional cohort approach to look at intermediate term effects, and this is the design that I'm going to talk about today. We're also using a marginal structural model to look at long-term or chronic effects. So iron and EPO are titrated in response to changing levels of biomarkers. So it's very difficult to study the long-term exposure effects. So we're using a marginal structural model that can control for these intermediate variables that are affected by past treatment and influence future treatment and are also risk factors for the outcome. And finally, we're using an instrumental variable approach. Ours is based on differences between dialysis units and how they use EPO and iron. So the idea is that a patient may be treated one way if he goes to a certain dialysis unit, but he may be treated a different way if he goes to a different dialysis unit. So we're trying to exploit this this kind of natural experiment to estimate treatment effects. So we have a variety of different outcomes that we're considering. We have our so-called effectiveness or beneficial outcomes. That's the decreased use of EPO or ESAs, hemoglobin levels, iron status, and we also have measures of quality of life, as well as a variety of safety outcomes, infection, which we've defined as being either a hospital admission for sepsis or vascular access infection, pneumonia, or infection-related death. We're also looking at various cardiovascular events, AMI, stroke, or cardiovascular-related mortality. We also have hospital admissions for anaphylaxis or drug allergy. So this is our basic design. You can see that. So this is for our study of short-term effects. So essentially what we're doing is we're trying to identify the first transferrin saturation lab that occurs after a patient starts dialysis. So this is a lab that usually triggers some kind of treatment, some kind of iron treatment decision. And so we assess the iron exposure in the 1 month period after the transferrin lab is available to the dialysis clinic. And then we look at outcomes that are occurring in a 3 month period after follow-up. So patients are censored if they receive a kidney transplant or change dialysis modalities, or we reach the end of data. So this is a fairly clean design. We have covariates defined prior to exposure, and we require the patient survives this exposure, this 1-month exposure period, and then we look at outcomes that occur after this exposure period. In various sensitivity analyses, we vary the lengths of these different periods. So we shorten the exposure period to 2 weeks, then to 1 week, and we consider different lengths of the follow-up period to see how sensitive our results are to these relatively arbitrary design decisions. So this is just a cohort construction diagrams. I think it's almost illegible. My apologies. But we wind up with about 117,000 patients, starting from a population of about 300,000 patients who initially who had data available from the dialysis provider. So we required various things, such as the patient must have continuous Medicare eligibility. We had a variety of exclusion restrictions. Okay, I don't know what happened to the font. This is a table 1. Looks like maybe we'll see it better on the big screen. Essentially showing the characteristics of the patients who received a bolus administration, maintenance administration, or didn't receive iron at all. I'm sorry, can you all see the numbers on that? Okay, I created this on a Mac, so I'm afraid that it didn't convert. So I'll just summarize. The demographic characteristics are well balanced between these three groups. They're very similar, but the patients who received the bolus administration were more likely to have had a history of infection, which was somewhat surprising, more likely to have a history of hospitalization during the baseline period, and were generally sicker than patients who received maintenance iron or didn't receive iron at all. Maybe it's just me that's having a hard time reading these. Is that equally illegible? Oh, okay. I'm sorry. Okay, I skipped over one slide here as well. So our statistical methods, we had two models that were, there seems to be a problem between the slides and the what's being displayed. I'm seeing a different slide on my screen. Okay. All right. My apologies. So we considered two different time-to-event models, the Cox proportional hazards model and semi-parametric additive risk model. So we're estimating both a hazard ratio and a hazard difference. Initially, we'd actually proposed to use inverse probability of treatment weighting here, but we had two treatments that were considering both use of EPO as well as use of iron. And as it turned out, the weight models became very unstable. We wound up with weights that are very large for some patients, and we found the results were quite sensitive to how we handle these very extreme weights. So I think this is an interesting sort of methodological issue that needs further research, and other folks have encountered this in other settings as well. So just want to point that out. So again, we varied the length of the exposure period and the length of the follow-up. So we considered, I'm going to have to just describe these to you since the slide didn't come out, but we considered all these different outcomes, the cardiovascular outcomes, infection outcomes, and various mortality outcomes. And what we saw was that iron was strongly associated with all of these outcomes in the crude, suggesting a lot of confounding potentially. When we adjusted for the clinical and laboratory variables in our database, we were able to bring most of those associations back to the null. However, infections remain significantly elevated in the patients who were receiving bolus iron. So even though the relative hazard was relatively small, it was about a 14% increase in the hazard, because infections are so common in this population, the absolute risk was quite large, suggesting that bolus iron causes about 4 additional infections compared to maintenance iron per 100 patients treated per year. So we also repeated this analysis across a variety of different subgroups, and most of these were subgroups that were proposed to us by our stakeholder panel. And what we saw was that the effect of iron varied a lot across the different subgroups. So we saw that bolus iron seemed to be particularly problematic among patients who had a temporary catheter. So these are patients who are at very high risk of infection compared to patients who have a permanent vascular access. And we saw that in these patients, bolus treatment increased the risk of infection by about 7 events per 100 patients treated per year. We also saw a significant increase in risk among patients who have a history of infection, and most of the other subgroups were relatively consistent with the overall association. We didn't see any change in cardiovascular risk associated with bolus treatment across the different subgroups, suggesting again that iron doesn't seem to have any short-term effect on cardiovascular risk. So this is a table describing the effectiveness outcomes. We found that bolus iron relative to maintenance iron increased hemoglobin by about 1/4 gram after 1 month. It reduced EPOGEN dosing by about 500 units per month, which is relatively small. It's about a 5% decrease in EPO dosing. It increased transferrin saturation, a measure of iron availability, by about 3%. It increased ferritin by 150 nanograms per milliliter. This is a measure of iron storage. And we looked at these associations across all the various subgroups that I've described, and we saw relative consistency of association across the subgroups. So not much evidence of treatment effect heterogeneity with respect to the effectiveness outcomes. So we did a variety of sensitivity analyses. Again, we shortened the exposure period by requiring a 1-month exposure period. We could induce we could create some selection bias. If a patient dies during the month because of a large dose of iron, for example, we would miss that event. We'd drop that patient from the analysis. So we wanted to change the length of the exposure period to see how that affected results. We didn't see that change had much effect. We also changed our follow-up period, and again didn't see much of effect due to that change. We added a lot of additional variables to our multivariable model, and again that didn't have much of an effect on the hazard ratios or hazard differences. We also stratified the analysis on dialysis facility. That widened the confidence intervals a bit, but didn't substantively change the results. We also looked at the contrast between maintenance dosing and no treatment and found no risk of any of the outcomes considered associated with maintenance dosing. So I'm sorry that the tables didn't come out, but one of the things that I was hoping to contrast with those tables is the difference between reporting relative measures of effect and absolute measures of effect. In a way, this is kind of Epi 101, but I think when you look at all the hazard ratios across the subgroups, you see a lot of homogeneity of these different measures of effect, but you see significant heterogeneity in the absolute measures of effect. And as well, when we're looking at the different outcomes, so we're looking at infection, stroke, myocardial infarction, all of these outcomes occur with a very different underlying incidence rate in the population. So you can see large hazard ratios with certain outcomes, but it results in a very small absolute effect. Whereas with the infection outcome, we saw a relatively small hazard ratio, but actually a very large absolute effect, in my opinion. So it also helps, I think, to have these relative measures of effect ultimately to communicate the results to clinicians and policymakers. Ultimately, you can talk about things like per 100 patients treated, you would prevent this many events, but you would cause this many events. That's something that's easily understandable, I think, to everyone. So in our study, we found that bolus use of iron raised hemoglobin by about 1/4 gram per deciliter. We saw about a 5% decrease in ESA dosing, but these are beneficial outcomes. But the cost of this is about 4 new infections per year per 100 patients treated. So I'm not a clinician. I'm not in a position to sort of to weigh off those risks and benefits, but it doesn't seem like a good trade-off to me. And in fact, we see that the trade-off is much worse in patients who have a catheter, who've had a recent infection. In those patients, we see a similar increase in hemoglobin, a similar decrease in ESA dosing, but about twice as many infections. So the risk-benefit trade-off there is worse. So we saw that maintenance dosing wasn't associated with any adverse events. So the results of this study so far suggest that the maintenance dosing may be a safer approach to providing iron, may be slightly less effective, but ultimately the sort of risk-benefit trade-off would need to be made by clinicians or policymakers. Thanks.
Thanks very much, Alan, and all of the speakers. We're a bit over time, but perhaps we have a couple of minutes for questions from any of the speakers. Yes. Please, again, go to the microphone and identify yourself.
Yeah. I have a couple of questions for Dr. Chaudhary. I hope I pronounced your name right. Very exciting paper. One question is, you mentioned that the randomization was blocked by the initial generosity. I'm wondering whether you have looked at how the experimental effect had any evidence of variation across by the initial generosity group. I guess the hypothesis is that those who had a more generous initial plans might have a smaller gap to fill.
Right. So that's an excellent question. So I've got two answers for you. So what we have presented so far is the results within the strata. So the strata are kind of tertiles of generosity. And so basic economic theory would suggest that, as you're articulating, but just to reiterate, that if your benefits at baseline are less good and you now give away drugs for free, the effect should be larger. As it turns out, that was not the case in what we've seen so far. And it seemed like the effect was relatively homogeneous, notwithstanding Alan's insightful comments about subgroup analyses. But the effect was homogeneous across that. And that might have been because even in the group with the most generous coverages, they were still paying about $40 a month out of pocket. And so there might actually, in economic terms, elasticity of demand may not actually be linear, although we believe it to be linear. There may be a threshold effect. And so it may be that even in the most generous group, we had exceeded that threshold effect. That said, the way that we did this from a purely methodological perspective was extremely challenging. We had to identify people at the time of randomization and assign a benefits generosity to their plan sponsor based on drugs that they may or may not have taken in the past, and based upon claims data which may or may not have been available if that plan sponsor was new. And so what we did was came up with a method to come up with a generosity estimator for each of these plan sponsors and assign them that way, which may have been inaccurate. So what we're doing right now is coming up with a better estimate of patient-level copayments before the trial went into effect to see if that's a better proxy for our block randomized design.
If I can ask a related question. So in some way, embedded in your study, there's also a quasi-experimental study for the control arm.
Right.
So, for the other research questions, well, you might not be able to afford to do the experimental study. It might be useful to look at how the three arms of different generosity compare and look to see how that relates to the experimental results.
More generally, your question is a great one from a methodological perspective, which is how do the results of even a randomized study compare to an observational one? And so one of the things that we actually have two methods of observation here. We have baseline utilization amongst a historical cohort of people who've had an MI and a group of opt-outs who didn't opt out because of disease risk, who opted out because of insurance considerations. And so what we're doing right now is actually comparing the results of our randomized intervention with those that would have been achieved. And Sebastian has done similar work 5-7 years ago now, and just to see if we had doing this randomized approach, as you heard, was a bit of a production. And maybe it was a little bit, I was going to say pain, but I think production is more polite. And it's doing this, if we'd gotten the same thing using an observational approach, then that would have taken us a lot less time to have done.
Maybe we'll find something different.
Maybe.
Yeah, very exciting.
Thank you.
Bruce Hilner, Richmond. I'm a general internist. I have a question for you, and then I have a question for the first speaker. It's very elegant stuff. I'm concerned that your time frame seemed to be too short. Was that a priori to just look at a year out? And then part B is that the people who were compliant over 80%, independent of the co-payment, I would expect from other work to have a better outcome. Did they have better outcomes?
So let me take the second one first, which is, I think, a little harder of a question. So in a randomized frame, we are actually conditioning out the fact that some people would or would not respond to an intervention. So some people are not going to use drugs for free, even if you give it to them for free. And some people will always use drugs, even if you have to pay a huge amount to that. And the benefit of a randomized frame is that we allow for equal proportions of those people in both of the groups, and we just change one of the variables. As it turns out, people who were adherent did better. And in fact, there was no effect even for moderate levels of adherence, achieving moderate levels of good adherence. So it really argues for the fact that you have to achieve high levels of adherence in order to see design effects. And there are massive methodological problems with this approach, which we're struggling with right now. But nevertheless, that's a basic observation. As to your first point of time frame, most acute MI recurrent events happen in the first year. In fact, there's a sharp decline in rate of events over time. If you have lived through your first year, then likelihood of recurrent events become exceedingly low. And so we did this on purpose, that we were looking at the first year's events, and we did see an effect that was large enough to reach statistical significance. So I would argue that 1 year is both clinically and even economically and policy relevant. Insurers think about things in 1 to 3 year time periods, especially for those people who are under age of 65. And so, it's always nice to have longer-term events. We do have long-term follow-up on some people out to 4 years, and the effects are not influenced by length of follow-up here. But nevertheless, I would argue that 1 year is actually a perfectly adequate amount of time.
For the first speaker, I have several concerns with it, but it seems that there's really two separate questions. One is ESAs around the time of initiating dialysis versus chronic dialysis. And where your co-information, just pulling this out, just doesn't, to me, I'm curious if you have an explanation that having only 14 to 16% of chronic dialysis patients having hypertension and 5% having diabetes seems tenfold off. So I'd be curious about what's going on with the data.
So I don't have the table in front of me. Is that from the incident population or the chronic?
Because
the incident population, that comes directly from the REMUS study report forms. It is not using the USRDS matched to the claims, going back and looking at all of the other history. It's essentially the medical history done at the time of initiation of dialysis. And the rates I'm familiar with are higher than 5%, but I work mostly with the incidence side, so it's the prevalent population of chronic cases, which would be, but those would still be those cases that, based on the status at the time of initiation. So there may be...
Again, I'm just saying it doesn't pass the clinical sniff test. That's one. And then for the incident cases, there's a whole lot of energy for clinicians to be sensitive to hemoglobin in the pre-dialysis chronic kidney disease, but pre-dialysis window for several years. I'm surprised that you just ignore that window of time, that the prior use or non-use of iron or EPOs you don't really include in the evaluation.
So the difficulty is whether it's the USRDS data or the REMUS data. That basically kicks in and starts at the time of dialysis when, for at least half of the patients, there's no prior Medicare history. So this is not linked up to the pre-dialysis clinical history of the patients where they're being managed by a clinical nephrologist. And in my conversations with people about sort of what's happening prior to that is the key in terms of understanding both the treatment decisions that are occurring at that time. And that's missing information right now.
I have a question for Dr. Chowdhury. First of all, that was incredibly elegant and beautiful study that you conducted. One of the things that I was struck by, which you pointed out, was the incredibly low rates of adherence, even in the study group. And it raises, in my mind, really a question about, what are the appropriate interventions to improve adherence, and in particular the cost effectiveness. And so bear with me for a minute. So the organization decided to go ahead and waive co-payments or co-insurance for these drugs. And it seems that for each patient, the average and fixed costs are the same for that. Each patient incrementally is the same cost when you add that. If you think of other successful strategies to improve adherence, like reminders, automated reminders and so forth, in the literature, the benefit seems to be about equal or perhaps even greater in terms of improving adherence. There's sort of a fixed cost up front for setting such a system, but the marginal cost per patient is much less. And I wonder if your study really begs for that next study to actually compare these approaches from both a sort of clinical outcomes and economic standpoint.
Yeah. So I think you've hit on a couple of critical points, and that ultimately costs are only part of the puzzle. I would argue that this study, if you buy the data, and to the extent that we have a truly randomized policy experiment, it's compelling enough that this one, like most economically dominant strategies, if it's saving us money or not spending any more money and improving quality, then I don't think we need to compare it to anything. That says, let's go ahead and do this, at least for this population of patients. Of course, we need to figure out whether this is the right idea for everybody, and I would be the last person to say that it is for every disease and for every condition. But maybe for this one, it's okay. But then think about what all the other targets might be. So electronic reminders are a great one. My view is that there are simple, scalable strategies, and that's really where we need to devote our efforts from a economic efficiency perspective. A lot of the stuff that exists right now are really high-touch, very involved, targeting non-adherent patients to begin with. And so the trade-off between those is an intervention that is maybe more effective but requires more resource and more cost, with one that may be blanketing a group of patients for whom would not benefit from it to begin with. And so from where we fall off as we move beyond costs into other things is not exactly clear. And what this body of research has really taught us is how to do these studies as we think about new ones in the same system. Thanks.
I'm Ulf Meyer-Krieche from Astellas. I have a question/comment for Dr. Moore. So first of all, I think this is a very nice study because it's supported by literature in terms of prospective trials, and also there's biologic plausibility. Though the higher mortality in the patients who are targeted to higher levels, I wonder whether that is to a certain degree confounded by an effect which is not measured. So clinically, we know that patients who are treatment-resistant to erythropoietin are clearly at higher risk for death. We also know that those patients get treated with higher doses of erythropoietin and then they overshoot. If you go in the dialysis unit, that's a significant concern because you're trying to push those patients into the target area and then you overshoot. So the question is, are you measuring partially patients who are actually resistant to erythropoietin and then overshoot, and they increase the risk for mortality?
No, I think that's a very good point. This was a much more speculative exercise trying to replicate a clinical trial where the experimentals were actually, or the exposed were actually being targeted to treat to a higher level than the quote-unquote controls as on the basis of the trial. And so what we did was basically use the observational data to say whose average treatment level was achieving or targeting to the 36 plus in the hematocrit level, or 12 and over for the hemoglobin, versus those in the 34. So it has all of that possible confounding by indication. The only positive is that the clinical trial of that same effect saw almost the same effect size.
My apologies for running late. We are really well out of time. Thanks very much. Thanks all the speakers.
So we're going to take a 5-minute break and then start the poster session, which will begin in the next room over. So overall, we'll have 30 minutes over the next, before we'll